about antepartum, antenatal, intrapartum, and postnatal care. So why do we actually provide antenatal care? Why we think it's important for pregnant women to be regularly seen by a physician? Yes?
Doctor, the students are asking for the slides, if you don't mind. You can share them with them.
You can't see the slides?
No, if you can send me the slide or send it here in the Zoom meeting so they can take notes with you.
How do I send them to the Zoom meeting? You can't see the slides, or you can?
They can see the slide, but they want them to take notes.
How can I send them now?
So doctor, you can open the chat.
Open the chat.
And there's a file. Just press on that and then pick the file that you want and just share it to everyone.
Open the chat, and then what do I do?
There's a file, right?
Yeah.
Press on that.
Yeah.
And then just pick up whatever file that you want to share.
Okay.
And that's it. Just share it.
Okay. Okay. Did you get it?
That's it. Okay. I don't know.
Yeah.
So I think that you just send it to Wafa. So just I'm gonna ask Wafa to send it to everyone, and that's it.
To Wafa. Why did it go to Wafa? To everyone. Okay.
Yes. Okay. They got it. Okay. Thank you so much.
Halas?
Yes. Thank you so much, Doctor.
Type. Okay. So basically, the aim of antenatal care is to make sure that the mother goes through the pregnancy without being like her health being jeopardized, and at the end of the day she delivers a healthy baby. How can we achieve this? There are few things that are quite important and throughout the antenatal care in order to achieve our final goal. First of all, the proper estimation or the calculation of the gestational age is extremely important. We need to risk identify patients with each and every antenatal visit. We need to reevaluate the risk factors, because many times we actually convert patients from being low risk into high risk. And that is not only for the mother but also for the fetus. We need to anticipate problems. So antenatal care is not to wait for the problem to happen and then deal with it. We need to screen for problems, and in order to prevent them from happening, or at least reduce the risk of happening. And obviously this can only happen if there is proper patient education. So when do we actually start antenatal care? We start antenatal care in the preconception period. This is a very, very important concept, everyone. So we need to start the antenatal care before the pregnancy happens. And there are some important concepts that we need to focus about in the preconception area, which might not be possible for us to do once the patient is pregnant. So basically, we have to avoid behaviors and exposures that might. Okay. Can you hear me?
Yes, doctor, we can.
Yeah, I don't know what's happening. Anyhow, so preconception care is extremely, extremely important. So we need to avoid behaviors and exposures that will affect the pregnancy, and provide an opportunity to inform the woman about what are the expectations of the pregnancy, what possible problems for that particular woman she could have. And obviously then we start the appropriate preventive interventions that are quite important. So remember that up to 30% of your pregnant women will not actually come during the first trimester for antenatal care. And therefore, unless you actually see the woman in the preconception care, you might not be able to change, like positive changes, conduct positive changes, and she might not be even aware that she actually needs to come for antenatal care in the first trimester. Okay? So this slide is basically just to tell you that by the time usually we are like 6 weeks in the gestation, the majority of organs have already developed, yeah? And therefore, if the women do not come in the preconception or have all the interventions done before she actually comes to the pregnancy care, which is usually around week 7 to 8, most of the organs have already developed, and if there is a potential teratogenic medication she's using, then it's already too late to do any changes at that stage, because already the teratogenicity, if it's there, it would have possibly occurred. So that's why, what is this? Okay, so these are some of the interventions that have been proven to have evidence if you actually implement them before pregnancy. Folic acid supplementation is very, very important, because like I've just mentioned, by the time she's already 6 weeks, for example, after she gets her missed period, she finds out that she's pregnant, she books with you, then already, especially the neural tube would have already developed, and therefore, if there is a possibility of neural tube defect, then maybe we are unable to actually reduce that risk or even prevent it. Rubella immunization is quite important to be done preconception. HIV screening is important, because if the patient was found to be HIV positive, then we need to start medications that will improve her health and will prevent mother-to-child transmission. Same applies for hepatitis, diabetes management, hypothyroid management, and so on. So all these, like avoiding, teratogenic medications, avoiding smoking, and so on. These are important concepts of the preconception care. I'm just going to give you some terminology. This is what we sometimes see. GT-PAL. G is the gravida. So gravida means the number of pregnancies, including the current one. So the patient will only be G if she is currently pregnant. T will be the number of term pregnancies after 36 weeks of gestation. P is the number of preterm pregnancies between 20 to 36 weeks. A is the number of miscarriages or terminations. And L is the number of living children. Sometimes you might see just G something, P something plus something. So it will be, G will be the gravida. P will be the parity. Can you still hear me?
Yes, hi, doctor, we can hear you.
Yeah, the internet is so miserable. I'm really sorry about that. Our hospital's internet is really bad. It doesn't allow you to project to the outside, so it's really bad. Anyway, so I was saying that sometimes you might see G Gravida 2, for example, para 1 plus 0, which means that she's currently pregnant. She has a previous pregnancy.
Doctor, if you want, try to speak out from your computer. Because every time you're speaking from your phone, there's an echo happening.
Can you hear me?
Yes, we can.
Okay, now you can hear me. But there's a lot of echo. Okay?
There is an echo.
That's the problem. Let me close this. Can you hear me now?
Yes, that's perfect.
I hope the computer continues to be fine. Okay.
Hello, doctor. Can you hear us? Dr. Usam? I think your connection is not stable, so we can't hear anything. Doctor, we're not able to hear anything yet.
It's very important to do that even in the preconception period before the patient gets pregnant, and the final.
Dr. Usam, students are not able to hear you at all. So they're not hearing anything. There is no voice. Dr. Usam, if you can log in from your phone again and speak from that, because we're not able to hear anything.
Doctor, we still can't hear you.
Dr. Wissam, can you hear me? Doctor?
Doctor, your sound's cutting off. We can't hear anything. Yes, doctor, we can hear you.
Okay, so you lost me some times ago?
Yeah, a lot of slides, doctor.
Okay, what do you want me to do? That's the problem. That's why I said it's better to stay on the phone because the internet in the hospital is not reliable. So where do you want me to go back to?
Terminology slide.
Huh?
Terminology slide.
Terminology? From here? Where?
Yes, doctor, here from the terminology.
From here you lost me?
Yes, we lost you from here.
Oh my God, that's half of the lecture. Okay. I don't know if I'll have enough time to continue the lecture. I have a clinic that will start already started actually at 9 o'clock. I have to be there in the clinic. Anyways, so terminology, let's just go through this. You heard the terminology, sir?
Yes, doctor, we heard it.
Okay. So confirmation of pregnancy, did we hear that or we didn't?
No, we couldn't.
Okay. So confirmation of pregnancy, a positive pregnancy test usually looks into the HCG. That's how we confirm the pregnancy, by the HCG, and it could be positive as early as 7 to 10 days after the fertilization. And the other things that we look for are the symptoms like amenorrhea, breast tenderness, nausea, and urinary frequency. The last menstrual period is the golden standard for evaluating a pregnancy, but the problem is that women don't always remember their LMP. They might have bleeding in early pregnancy where they think that it's a period while it was actually bleeding. They might have been on contraception. They maybe have irregular cycles. They maybe have a recent pregnancy or they're breastfeeding. So it's not always reliable. And therefore, only maybe up to 50% of your women will actually have a reliable last menstrual period, by the remaining will not. And therefore, we have to date the pregnancy by other means, and we'll come back to that in a minute. So how do we calculate the expected date of delivery? Usually we take the first day of the last normal menstrual cycle, we add to it 9 months, or we subtract 3 months, and we add 7 days. So it's basically, it's a 40 complete weeks, but we have to assume that we can only do that if the patient has a regular 28-day cycle, because this is how the calculation is. If the patient does not have a regular 28-day cycle, then you will not be able to confirm the expected date of delivery based on the LMP. Okay, we can skip that. We already spoke about that. Ideally, antenatal care should start in the first 10 weeks of gestation, usually by week 10. And the percentage of women who actually present for antenatal care by 10 weeks of gestation is one of the key performance indicators for the quality of maternity health care in a country. And the more women who are presenting to you in early pregnancy, the better your antenatal services, the better your patient education, and hopefully the better your pregnancy outcome will be. This is a small study that we actually conducted in Saudi Arabia. And here it tells us that between 1995 and 2009, there has been a massive improvement in the percentage of women presenting for early antenatal care. So we mentioned that LMP is the gold standard for evaluating the gestational age, but there are other things that are quite reliable, such as the date of conception, especially for women who had like ovulation induction, they're under infertility treatment. So we would exactly know when did ovulation happen or when did fertilization happen. A positive pregnancy test that happens immediately at the time of the missed period is very reliable. Otherwise, other methods such as when did the patient feel the fetal movements, if we can listen to the fetal heart, if we can measure the uterus at the umbilicus, are totally less reliable, with a difference of up to maybe 3 weeks, so we cannot really depend on them. Early pregnancy ultrasound is the best criteria for dating a pregnancy. And we do that to confirm the presence of an intrauterine pregnancy and therefore to exclude an ectopic pregnancy. We check for viability. If we see a positive fetal heart, we know that the fetus is viable. The number of fetuses, like in this picture, there's a twin pregnancy, and we date the pregnancy. The dating in the first trimester is by a measurement that we call the CRL, or the crown rump length, which is basically the measurement of the fetus from the head to the bottom. Obviously, you cannot see the limbs. The fetus is too small at that stage. So we measure the head to the bottom, and this is what we call the crown rump length. Crown rump length is quite accurate. It's plus minus 5 days. So if the difference is more than 5 days, then ultrasound is going to be more reliable, and we will date the pregnancy based on the ultrasound. But we can only measure the crown rump length in the first trimester, and the accuracy of 5 days is only up to 9 weeks of gestation. After that, the accuracy becomes plus minus 7 days. And after 22 weeks, it's not even reliable anymore because the accuracy could be up to 2 weeks. So the earlier, the better. And if we don't use the crown rump length, if we are using the other ultrasound measures, then the accuracy is up to 7 to 10 days if it's done before 22 weeks of gestation. Okay? Once we identify the expected date of delivery by either LMP, confirmed by ultrasound, or purely by ultrasound, we keep that and we evaluate the patient, the fetal growth based on the estimated gestational age. We do not change the EDD anymore, okay? And remember that the EDD we give the woman is the 40 weeks, but obviously not all women will deliver at 40 weeks. Women will deliver between 38 and 42 weeks, although in modern obstetric care, we usually don't allow women to go much beyond 40 or 41 weeks of gestation. Can you still hear me, guys?
Yes, doctor, we can.
Okay. So education during pregnancy is very important. We need to educate women with regards to nutrition. Usually we advise them to slightly increase their calorie intake, maybe by 300 kilocalories starting from the second trimester. If twin gestation, obviously they need to increase a bit more, but we don't double their calorie intake because that's totally unhealthy. We always advise them on healthy lifestyle, healthy eating habits, exercise. They can continue to exercise if they are used to it, but usually we don't start a new exercise during pregnancy. We try to avoid substance abuse such as smoking or alcohol. Traveling is quite safe. Sexual activity is quite safe. Medications, ideally, we should have checked them in the preconception period. And if the patient is on a medication that is potentially teratogenic, we need to stop it in the preconception period. And obviously, we evaluate the fetal growth and developments with each visit. The initial visit is ideally before 10 weeks of gestation, and we call that the booking visit. Subsequent visits are usually occurring depending on the risk factors that the patient has, but there are some important landmarks for the care of the woman. The first important landmark is at 11 to 13 weeks of gestation, where we do the first trimester ultrasound. Then we do the second important landmark at 20 weeks of gestation, where we do the second trimester anomaly scan. Then 24 to 28 weeks, where we do the second important antenatal investigations, and then a visit at around 36 to 38 weeks, where we do the GBS screening, the Group B strep screening, and we start planning the delivery. The visits in between, we actually do them customized. So it's basically based on the risk categories that you identify in the patient. You will decide when to see the patient. So there's really nothing called, I have to see all patients every 4 weeks in the second trimester and then every 2 weeks or whatever in the third trimester. No, you customize your care based on the risk categories that you actually have. So these are the important history points, like any other, encounter. And the booking visit, which is the first antenatal encounter, we have to make sure that we calculate the gestational age. We look for past obstetric or gynecological history that might have an impact on the current pregnancy, medications, any medical history, medical diseases that might have an impact on the pregnancy, or the pregnancy might have an impact on the disease. We need to evaluate in the booking visit and to identify the risk categories that the patient has. So risk assessment will include personal history, past obstetrical history, personal and family medical history, past surgical history, genetic history is very important, psychological, if there's any diseases, psychological disorders, partner violence, and so on. And then we generate a problem list. And this is the list that we're going to be re-evaluating with each and every subsequent visit. Booking investigations, we need to look at the height and the weight, the BMI, vital signs, a complete physical examination, including a breast examination, abdominal examination. We don't usually conduct a pelvic exam in pregnancy unless the patient is due for a pap smear because she had a previous abnormal pap smear, or if she has symptoms such as bleeding or something like that, we might be conducting a pelvic exam, or there is like a possibility of sexually transmitted diseases or so on. Otherwise, we don't usually need to do a pelvic exam at the booking visit. Usually, we can listen to the fetal heart by this. This is an instrument that we call the Dopp tone. Usually, we can listen to the fetal heart once the uterus is actually in the abdomen. And the uterus becomes in the abdomen after 12 to 13 weeks of gestation. Because before then, the uterus is going to be a pelvic organ. It's in the pelvis. Can you still hear me?
Yes, doctor.
Okay, good. So what are the antenatal visits that we actually do at booking? We do CBC, looking specifically for the hemoglobin, the hematocrit, and the platelet count, the blood group, and the antibody, the Rh type, and the antibody screen. Serology, usually we test for syphilis, for hepatitis B, varicella, and rubella. We check for HIV. This is routinely recommended for all pregnant women. We screen for diabetes if we are dealing with a high-risk mother, and usually our population are high risk, so we always have to screen for diabetes. We always do urine analysis and culture because a lot of pregnant women might have asymptomatic bacteriuria, and then we do targeted tests depending on our findings. So if she is at risk of hemoglobin of sickle cell disease or thalassemia, or there's, like I said, sexually transmitted diseases possibility, then we do targeted tests. But these are basically the important screening or booking tests that we do for all women. And then the test that we do at 24 to 28 weeks, usually we repeat the CBC. If the patient is Rh negative, we will check her blood group and antibody screen. And if she's negative still, then we have to give her the ROGAM or the immunoglobulin to prevent her from developing Rh isoimmunization. And we do the diagnostic test for diabetes, which is usually the GBS. Which is usually the GTT. And then at 36 to 38 weeks, we screen for group B strep. Okay, so we can skip this. Okay, hemoglobin obviously is quite important, and because to check if there's anemia and if there's a possibility of thalassemia. Platelet count is very important because women can develop what we call gestational thrombocytopenia. So having a baseline at the beginning of pregnancy is quite important. If we actually develop low platelets later on, then one of the diagnoses could be gestational thrombocytopenia. Usually anemia in pregnancy is diagnosed if you have a hemoglobin less than 11 grams per deciliter. And if we actually are having low hemoglobin, we always have to test for the serum ferritin, because if the serum ferritin is low, then we confirm the diagnosis of iron deficiency anemia. And now the modern management is to actually give iron supplementation to all pregnant women, starting as early as possible in pregnancy, just because the risk of anemia is very, very high during pregnancy and in the postnatal period. And anemia actually has an impact on the mother and on the fetus. Obviously, it decreases the educational performance, the work capacity, and the productivity, and increased pregnancy complications, including preeclampsia, low birth weight, prematurity, perinatal mortality, and even later on in neurodevelopmental delays if the infant had anemia for the first few months after birth. Folic acid, obviously, we said we start in the preconception and we continue for the first 3 months of gestation, but then the prenatal vitamins, the iron, the vitamin D, and the calcium are usually recommended for all pregnant women. We mentioned about urine culture, and we said that asymptomatic bacteriuria could be present in up to 10% of pregnant women. And if we don't treat that, they are likely to develop pyelonephritis in up to 20 to 30%. And therefore, if we find asymptomatic bacteriuria, we have to treat the women by antibiotics and then repeat the cultures usually 7 to 10 days after the completion of the antibiotic course. If we find GBS bacteriuria, we have to treat, but the presence of the GBS bacteriuria indicate that the women are actually highly colonized by this group B strep, and therefore we have to give her prophylaxis during labor, prophylactic antibiotics during labor to prevent the transfer of this bacteria to the fetus, and potentially could have like a bad consequences with morbidity and mortality on the fetus. Just gonna skip through these guys because we otherwise we don't really have time. So we said that we have to screen for rubella, varicella, syphilis, hepatitis, and HIV. Why screening for these are quite important? Because you can advise the woman to avoid getting the infection, and for things like HIV, because there is a specific treatment that will actually improve the outcome of the mother and reduce the risk of maternal to child transmission from as high as 30% if the mother does not receive the antiviral therapy to as low as less than 2% if the mother receives the antiviral therapy. And therefore, this is not only for the well-being of the mother, but also for the well-being of the fetus. Sometimes we do like specific genetic testing. Here we do it in the premarital, but sometimes if there's like a specific family history of a specific genetic disease, then we need to do a specific like targeted genetic testing for that specific population. And we always counsel mother with regards to screening for Down syndrome, because it's the most common chromosomal abnormality among live-born infants. How do we screen for Down syndrome? Age is quite important. The older the mother, the higher her chances of actually having a child with Down syndrome. We do the nuchal translucency, which is the ultrasound that we do in the first trimester, which has a very good detection rate of up to like 70-75%. And if we add to it the first trimester biochemistry, which is the HCG, human chorionic gonadotrophin, and the PAP-A, or the pregnancy-associated plasma protein A. If we add that to the nuchal translucency in the first trimester, we improve our detection for chromosomal abnormality up to like 80 to 85% detection. If we miss the first trimester, then we can always do the second trimester biochemical screen, which we call the triple or the quadruple test, that has a detection of around 65 to 70%. Nowadays, probably you heard about what we call the cell-free fetal DNA, or the NIPT, we call it, NIPT. And this is a blood test that we take from the mother and has a very, very high detection rate for the classic chromosomes, which is 21, 18, and 13. For 21, the accuracy is all the way up to like 99%. So it's still a screening test, but it has a very good accuracy for the detection of chromosomal abnormality. And obviously, we do the second trimester ultrasound, like I mentioned earlier. So this is what we do in the first trimester. Like this is the nuchal, the normal nuchal translucency, which is the thickness at the back of the neck. If we see this as this picture, which is enlarged, then this fetus is at increased risk of developing pregnancy complications, such as chromosomal abnormalities, and even if the chromosomes are normal, then other genetic diseases or structural abnormalities could actually be found. In the second trimester, we usually at 20 to 22 weeks of gestation. Can you hear me?
Yes, we can, but it's echoing.
Can you hear me?
Yes, now we can.
Okay, done. So when we do the 20 to 22 week ultrasound, we look for the complete anatomy. So we really look for all the organs in the fetal body, and to make sure that we are assuring the presence of normal structure. Remember, ultrasound looks at structure, it does not look at function. So even the presence of a normal structure does not indicate that the function of that organ is going to be normal, but at least we have excluded structural fetal abnormalities, and some of the structural abnormalities could pinpoint towards either a genetic disease or towards a chromosomal abnormality. Okay, remember what we said earlier, that we have to reevaluate the risk with each and every visit. And the important things that we ask about will include fetal movements, if there's any bleeding, any uterine contractions, any abnormal discharge, any pressure feeling, any dysuria. Obviously, edema is quite common, but sometimes, like non-dependent edema could be important. And if there's any psychological or psychosocial parameters. We examine the symphysis fundal height, and this is usually something done in the late second trimester and in the third trimester. We listen to the fetal heart, and we do general examination as indicated. Obviously, the danger signs are pain, bleeding, chills and fever, dysuria, edema, fetal movement changes, and watery discharge from the vagina. So the subsequent visit, like what I mentioned earlier, it's going to be decided based on the patient risk category. If she is high risk, then we might need to see her more frequently. If she is low risk, then maybe we can see her every 4 to 6 weeks, all the way up to 28 weeks, and maybe every 4 weeks later on. And then once she starts reaching like 34 to 36 weeks, maybe we need to see her every 2 to 3 weeks, and so on. So we really customize the visit based on the risk categories. Low risk women might require only 7 visits, and high risk women might require maybe above 10 visits. So we customize the care. Gestational weight gain, although it's not really important for us, except in the really underweight women and the really obese women. So in the underweight women, just because it might be associated with a smaller fetus, so we really look into the gestational weight gain. And the obese women, we actually want to limit their weight gain to avoid, the risks of like fetal macrosomia and so on. So otherwise, the weight gain is really not a very important criteria that we look at. It's important for the woman herself, but for us as managing physician, it's not very important. But the normal weight gain would be something between 5 to like 15 or 18 kilograms, depending on the initial BMI of the woman. Uterine size, like I said, usually in the late second trimester and then the third trimester, we measure the symphysis fundal height, and this is how we measure it. We measure it from the fundus, which is, the upper part of the uterus, all the way down to the symphysis pubis, or the pubic bone. Obviously, it's not a very accurate measure, because if the fetus, for example, is in transverse lie, then the measurement is going to be smaller. If there is increased fluid or reduced fluid, if you have multiple gestations, if the fetus is small or large, then it's quite inaccurate, but it's a simple test. It's readily available. It does not cost anything. It can be done within 2 minutes, and you can apply it to everybody, even the low-risk population. And therefore, it's a good test to actually evaluate the sort of the fetal growth. And if there is a difference of more than 2 centimeters up to 32 weeks, and up to more than 3 centimeters after that, then you will be suspicious of either reduced growth or increased growth, or increased or reduced amniotic fluid, and then we'll have to order an ultrasound at that stage. Then how we measure the lie and the presentation of the fetus is by what we call the Leupold maneuver. So the Leupold maneuver has 4 actually maneuvers. So first of all is the fundal grip. So we need to evaluate what occupies the fundus, whether it's the breech or it's the head. And then the umbilical grip, which is at the level of the umbilicus, just to evaluate which side is the fetus lying. Is the back on the right side or on the left side? And then the pelvic grip, just to evaluate what occupies the pelvis. And we compare that, the hardness of that with the hardness on what was up in the fundus. So just to evaluate whether this is the head down and the breech is up, or the other way around. And also we can just move our hand to check whether that presenting part is actually deep in the pelvis or it's not engaged. And then sometimes we do the 4th maneuver, where if our fingers were able to go beyond the presenting part, it means that the presenting part is still up in the abdomen and it's not engaged. Okay, so that is the Leupold maneuver, and it's to determine the fetal position, the lie, and the presenting part. Third trimester ultrasound, we do it sometimes. It's not routine for everybody, but if we do it, we usually do it to evaluate the fetal growth and the fetal well-being by doing the biophysical profile and doing the Doppler ultrasound. This is like a recap of the antenatal care that we do. This is a nice slide that you can look at. So everything that we do throughout the gestation is actually entered in this antenatal care timeline slide. Just few words about immunization. There are some immunizations that are recommended during pregnancy, such as influenza vaccine that we give during the influenza season, regardless of the gestational age. So even if the patient was in the 1st trimester and it's the influenza season, we can still give her. The Tdap now is recommended to be given between 27 and 36 weeks of gestation, and it's recommended for each and every pregnancy. Obviously, the things in red, like the varicella, the zoosters, the MMR, are contraindicated in pregnancy. So what happens during labor? So labor and delivery, labor could start either spontaneous or we can induce labor. Women can deliver either vaginally or by cesarean section. Usually the signs of labor will include contractions, rupture of membranes, mild bleeding, and loss of the mucus plug. Usually whenever the patient is coming with suspected labor, we always have to do an abdominal examination, which is the Leupold, and we always have to do a vaginal examination to assess the cervical dilatation and other. Can you hear me?
Yes.
Okay. Okay, so this is basically the changes that happen in the woman at the time of labor, and we really still don't know what stimulates labor. Does it come from the ACTH from the fetal pituitary, increasing the cortisol and therefore increasing progesterone synthesis, reducing progesterone synthesis, and therefore prostaglandin increases, and that's what stimulates labor? Is it coming from the maternal hypothalamus? There's a lot of theories, and we don't really know what stimulates labor. So this is just for you, like a recap. I'm sure you took that in your basic science. During labor, it's very important. Once the patient is in labor, we admit the patient, we evaluate her vital signs, we put IV access as required. Usually in our community, we do put IV access, and we always monitor the woman by what we call CTG, which is the cardio tocogram. Cardio is the fetal heart evaluation, and the toco is the maternal contractions. Pain control is quite important, and providing, you should have the service where you provide adequate pain relief during labor, including epidural, sometimes, morphine or pethidine or Entonox. So that you need to make sure that the woman is actually with adequate pain relief, whether this is by psychological, by medications. You need to decide what is best for your particular woman. There are 3 stages of labor. The first stage is from the dilatation, start of the dilatation and the effacement and the descent of the fetus. The second stage is the delivery. So once you reach full dilatation, then the delivery of the baby. And the third stage is the delivery of the placenta. So these are basically the first stage of labor. There is the initial or the latent phase, and nowadays we call that all the way up to 6 centimeters of dilatation is still considered the initial or the latent phase. From 6 centimeters up to full dilatation is the active first stage of labor. And then the second stage, which is basically the delivery of the baby. And the third stage is the delivery of the placenta. This is how the baby will make his way down into the birth canal. First, the head will get engaged, and then it will descend further into the pelvis. There will be flexion of the fetal head. Then the head then the body of the baby will rotate, and then there'll be extension of the fetal head, and then the fetal head at that stage would have reached the perineum, and as it reaches and touches the perineum, it will undergo external rotation and then the expulsion. So you will see that later on in simulation labs, maybe by next year, inshallah. Episiotomies. We don't usually do routine episiotomies. We only do them if they are required, such as suspecting a big fetus, or if there is a need for an instrumental delivery. Otherwise, we try to avoid episiotomies as much as possible. And usually when we do episiotomies, we can either do them mediolateral or midline. Midline is quite good, but remember that the anus is just there. So if you do a midline, it might extend into the anus, and you might end up by having a 3rd or a 4th degree anal sphincter injury. So therefore, if you really need a large episiotomy, you usually do it as mediolateral. And once we cut, or if the patient develops a tear, we always have to resuture that. Postpartum hemorrhage is a very important complication. And usually the most common cause is uterine atony, although other tears might actually also happen. Let's now. Cesarean section sometimes is the recommended delivery method. And usually this happens if there's previous cesarean sections, if there's failure to progress in labor, some specific maternal illnesses, if there's placenta previa, antepartum hemorrhage, severe preeclampsia, fetal distress, breech presentation, and so on. The routine postpartum, sorry, I'm brushing because we are out of time actually. The routine postpartum care after the delivery, we need to check that her vital signs are normal. There is no infection. The breast is fine. It's not engorged. There is no signs of infection in the breast. The uterus is well contracted, that the patient was able to urinate, and no other problems. We make sure that there is no mastitis, and if there was an episiotomy or a tear, that we have evaluated it. If there is no abnormal bleeding or postpartum hemorrhage, always think of thrombosis, because the risk of venous thrombosis is increased actually in the postpartum period, and many times we need to give the woman thromboprophylaxis. Counseling with regards to contraception is very, very important. We always have to do that in the immediate postpartum period, and you should not allow women to leave the hospital without being counseled and she has already decided on a contraceptive method. And if not, you need to make sure that she has an appointment to see you to give her the contraceptive counseling again. So there are many different methods. I'm just going to skip that because we really don't have time. And the postpartum check, usually we do it at 6 weeks and we make sure that the uterus is back to normal, that the patient is breastfeeding. Sometimes she might have menstruation, sometimes she doesn't, especially if she's breastfeeding. If she hasn't had a recent pap smear, we need to do the pap smear and re-educate her about nutrition, supplementation, and contraception. That's it. I'm really sorry about the rush. I'm really sorry about the bad internet. And on Thursday, I'm just going to make sure that I get my personal computer to give you a better lecture. Any questions? I'm not sure we have a lot of time, but if you have any pushing questions, please, you can ask. Any questions? Hello, can you hear me?
Yes, no, thank you, doctor.
All right.
It's all clear.
All right, thank you.